Good morning, everybody. Welcome to Phoenix Children's Grand Rounds. My pleasure to introduce our speaker today, Dr. Michelle Monkwitz. And Dr. Monkwitz is joined by an esteemed panel, which we'll introduce about halfway through. We have a, I think, fascinating discussion this morning on parental authority and its limits. Dr. Monkwitz is a pediatric intensivist at Phoenix Children's. She serves as the Associate Program Director for the Pediatric Critical Care Fellowship, and she also serves as Chair of the PCH Bioethics Committee. Dr. Monkwitz.
Thank you, Dr. Olson. So first of all, I have nothing to disclose and no conflicts of interest. I will be recommending some books and articles, but only because I think they're very helpful. So today, the objectives of our talk is first to define standards that we should use when we're making decisions for others, to differentiate the standards that we use for children versus adults. We're going to discuss the role of family in society, including the obligations and the rights of parents. We will consider the developing child's autonomy and decision-making. And finally, we will discuss thresholds for overriding parental decisions. So as we go through the beginning of this talk, I would like you to consider two cases. The first case is an adult patient who has suffered a severe brain injury and requires life-sustaining technology in order to prolong their life. And the second scenario is a young child with that same brain injury. So for surrogate decision-making, this is how we make decisions for those who cannot decide for themselves. And the authors of this book, Deciding for Others, outline four questions that we should ask ourselves when we're making decisions for other people. The first is, what values should be promoted by surrogate decision makers? The second is, who should actually the surrogate decision maker be? What guiding principles should the surrogate adhere to? And finally, when and by whom should the surrogate's decision be overridden? So when making decisions for others, there's a traditional hierarchy that we have used to make decisions. The top of the hierarchy would be, this would be the very best if the patient has advanced directives, and then we know exactly what it would be that they would want in any given situation. In the absence of advanced directives, we then use the substituted judgment, which we'll talk a little bit more about. And finally, if we not able to use that standard, then we use the best interest standard. And this is traditionally what we have used. So substituted judgment is what a patient would have chosen if they could. And this does require maturity and the development of values. And so that we're talking about adult competent patients that we use the standard for. And we would know what it is, their values, if they have written them down in journals or letters, direct conversations, very specific conversations with the patient about what they might want. And finally, if we don't have any of that, just general knowledge of what the patient would want. So in our adult patient with the traumatic brain injury that didn't have advanced directives, a surrogate that is making decisions would need to ask, what would the patient have wanted? Instead of what would I want for this patient? Would the patient have preferred prolonged length of life, chance of recovery, or would that patient want life only if it could be lived as she was prior to the injury? If we don't have any idea what the patient would have wanted in this situation, then we use the best interest standard. So this is when we don't know what the patient wants. This standard is based on the protection of patient welfare. It is the standard that we use for children regarding medical decision-making, as they have not reached most of our patients haven't reached the age where they have developed their values and can make decisions on their own. And really the bottom line is, all things considered, what is the choice that produces the greatest net good or benefit? So for our young child with that same injury, this is a patient who doesn't have decision-making capacity, partly because of their injury and partly because of their developmental stage. So what is the good net or benefit for the child? The parents should be considering the burdens and the benefits of treatment and who that patient is and what the hope is for who they will develop. What is the net good, who decides what that net good is? And if you're thinking about these questions, if you're like me, you might start to feel a little bit of angst because there's not really, one good answer to a lot of these questions, and this is really where a lot of value judgments come in. So the problems with using the best interest standard is that it's very difficult to precisely define what the best interest of the patient is. It's inherently a question of values, and different reasonable people could disagree on what is the best interest. It doesn't help us decide whose conception of the child's best interest will prevail. Is it the family, the parents' best conception? Is it the medical teams? And this inherently involves assessment, trying to weigh which values carry the most weight. The nature of these interests are very complex. It is not simple to weigh the benefits of the chance of survival against the burdens of treatment. Many times the treatment itself does have side effects and it does have risks associated with it, and trying to weigh those risks against the chance that we're going to be able to prolong the child's life and get them to maturity is not an easy thing. Also, the best interest standard does not help us determine when parental decisions should be overridden. So standards for surrogate decision-making for children, we've talked about best interest, and we've talked about the reasons why that's not really good enough. And so there are several ethicists who have given opinions and written extensively on this. And one of them we're going to talk about is Dr. Ross, who has developed a theory of constrained parental authority. And this kind of goes steps beyond best interest and really takes into consideration the child's developing personhood, their developing values, their potential to become an adult, and really depends on their degree of competency, their degree of ability to be autonomous, as well as the family's influence on their value system. And then finally, we're going to talk a little bit about, what is that harm threshold for overriding parental decisions if best interest is not good enough? So to answer the question, one of the top 4 questions about surrogate decision-making, who should that be for children? And this seems like a very obvious answer to most of us. I think most of us would agree that in most cases that the parents are the best surrogate decision-makers. But even though that is obvious, as is many things in ethics, there are lots of ethicists who have written extensively, given opinions on who should be the decision-maker. And so parents that care about their children, and they are usually the ones that know their children the best, and they know their needs the best. The parents are the ones who bear the consequences of the treatment choices. And society gives parents the right to raise their children according to their own standards and values, and to pass those values along to their children. We see family as a valuable social institution, and it's important to foster intimacy, which requires freedom within the family. Families make important decisions regarding the welfare and well-being of its members.
So I'm going to chat for just a few minutes about parental obligations and rights within the family and expand on what Dr. Monkowitz was just telling you about. Next slide. So we're very much aware that parents are obligated to provide for their children's basic needs, but what's often overlooked, or we just assume, is that the family is also essential in the moral development of children. That is, we assume that adults can devise and implement their own life plan. However, this would also include raising their family or their offspring or children or inherited children according to whatever their conception of good entails. And this will differ from person to person. Next slide. American society historically is actually rooted in this tradition that family is the primary source of value formation. That is, until children are assumed capable of formulating and articulating their own values, which typically we don't ascribe to them until they reach the age of majority or 18, we would ascribe the parental values onto them, and a parent or guardian is assumed to speak for that child. There are currently several statutes that will protect the role of parents in making choices, often involving decisions including education, religion, morality, and as it stands, most of the time, when two value teaching institutions collide, for example, a hospital with a family, a school with a family, a church with a family, the family is typically given the ultimate right to instill whatever decision or values that they think are best. Next slide. And why do we do this? Well, we typically do not assume decision making to minors because we know that their frontal and prefrontal cortices are not fully developed until young adulthood. And of course, now we realize that they don't fully develop until later than 18, but the age of maturity is still currently 18. And in this sense, we keep the decision making with guardians or adults because we know that capacities like judgment, executive functioning, planning, and other processes that are essential in core and sound decision making are not fully formed. However, this does not mean that minors should not be involved in decision making at all, or these decisions should occur away from them and without their input. In fact, we know that minors really should be participating in medical decision making, commensurate with their developmental level and their ability. There is a tremendous amount of literature that's found that when youth are excluded from participating in decision making when they're capable of doing so, it leads to higher levels of distress, poor coping, loss of control, strained relationships within the family. And so there are really some pernicious outcomes if we try to shelter youth by not allowing them to participate at all. And so the way that we want to include youth is, of course, they can't give consent, but we want to assume that they can give assent, typically once they're over the age of 7 or 8. And assent is this process that allows a minor's voice to be heard, and it allows them to participate in decision making. Some examples of procedures or events and decisions that should require assent, contingent, of course, on that youth having capacity to engage, would include receipt of transfusions, initiating or stopping chemotherapy, listing for transplant, elective surgery. Of course, the list is much more exhaustive than that. Next slide. So the last thing I want to chat about is what actually is assent, because I think that a lot of times when decisions have to be made quickly, assent can sometimes be conceptualized as, here's what we're going to do, is that okay? Okay, great, and then they move on. And truly, assent should be a 3-step process. The first step is that the youth needs to be provided developmentally appropriate education and an explanation of what's going to occur, the risks and the potential benefits, as well as making sure that they have just an overarching understanding of their diagnosis as a whole. The second step of assent is that you have to make sure that that minor actually understands the information that they were given. Oftentimes you can achieve this through a teach-back method. And then finally, the third step is soliciting an expression of the minor's willingness or unwillingness to allow treatment. And this can be verbally or non-verbally done. Next slide.
So I'm going to talk for a minute about Dr. Ross's theory of constrained parental autonomy. And in general, the idea is that children should be provided with the tools that they need to become autonomous adults, capable of devising and implementing their own life plans. And she talks about accommodating inter-familial trade-offs, provided that the basic needs of each child are met. So one of the examples that she talks about is, consider a child who needs some rehabilitation, physical therapy, and lives in a rural area. And the family's means of support are they live on a farm. And the child has an injury and now needs this rehabilitation. And in their rural community, they do have some rehabilitation services, but it's not as sophisticated as, say, if they had moved to the city in order to get better rehabilitation. So we allow families to decide for their families what's best for this. And instead of saying, well, the very best thing for this one child would be her physical therapy and having the best rehabilitation, what is best for the entire family is to be able to live where they can make a living and be able to provide for all of their children's needs. So really important to consider all of the things within a family when they're making decisions. And also she places a lot of weight on considering the child's development of autonomy as the constraint. So, keeping in mind that the family is developing their values, and as they develop, they're becoming more and more able to have an opinion and participate in that decision-making process. So I want to talk for a minute about overriding a parent's decision. There are many times when we recommend a treatment path and our families will disagree with that treatment path and sometimes refuse the treatment that we really think is necessary to prolong a patient's life. If a parent does refuse a treatment and the medical team has recommended and it's a life-saving, life-prolonging intervention, the state can intervene and appoint a decision maker for the child under the claim of medical neglect. And neglect has been defined as the minimum quality of care the community or society will tolerate. So this is a great article that I would recommend that everyone read. And this really talks about that harm threshold. So I'm going to just give a brief overview of some recommendations. There are 8 questions or 8 recommendations, considerations that we should think about before we make the decision to override a parent's decision. And this is defined as the harm threshold. So first of all, by refusing to consent to the treatment, are the parents really placing their child at significant risk of serious harm? And serious harm means serious morbidity or mortality. Is the harm imminent, requiring immediate action to prevent it? I think this is a really important one. Many of the times we feel a lot of angst and we can see down the road what's coming and we feel that it's really imminent. But really asking ourselves, are we in the hours today's category that if we don't intervene, that significant harm is going to prevent the bad outcome? Or do we have a little bit of time to work with the family? And if the is the intervention necessary to prevent the harm? Or is there a low likelihood that the treatment is going to prolong the patient's life or to benefit them? And are there a lot of risks associated with that treatment? Is the intervention proven? Is this our standard of care? And then the question of the intervention itself. Is this an intervention that gives serious side effects? And do the benefits of the treatment actually really outweigh the projected burdens significantly more favorably? In going through this talk, I read through a lot of literature, and specifically in the oncology literature, and I was really surprised to find a lot of articles that really talk about a lot of the burdens of treatments. And since I'm not an oncologist, I didn't realize how much thought really goes into that when making those decisions with families, but really important to ask this question. And then ask ourselves, is there any other option that would prevent serious harm to the child in a way that's less intrusive to the parental authority and more acceptable to the parents? Can the state intervention be generalized to all other similar situations? So making sure that we're treating patients fairly. And finally, would most parents agree that the state intervention is reasonable? So if we go through those list of questions and we see that this really doesn't meet criteria quite yet to really force the hand of overriding the parent's decision, and we find that we actually do have time to work with parents, but we're really still at an impasse with families. And definitely in critical care, we find ourselves in this situation a lot where conflict is just escalating and it doesn't seem like we're going to get resolution of the problem. So this is a book that I want to talk about, Breaking the Cycle, and if there's anything that you get out of this talk, I would recommend that everyone listening read this book. It's a really fabulous book. I'm going to just talk about it from a really high level and just give highlights of it. So the background of this book is there are psychologists that wrote this, and they are experts in systems interventions for families that are in trouble, and they took those same principles to apply to interventions in the doctor-patient relationships. So usually how it works is that physicians are seen as the expert, and that our patients come to us because they have a particular problem. The patients and the families view us as physicians as an expert. We accept that role as an expert, and then we diagnose and treat, and hopefully the problem resolves and the patient gets better and is able to go on with their life. Sometimes what we have recommended doesn't work. The problem continues, or sometimes it even gets worse, or there are other problems, and we kind of go back and assess that. And again, we're given the expert title, we accept that, and we continue to do our work. However, when that doesn't work so well, when conflict arises, and this is a part that when I was reading the book that really struck me probably more than anything, in this point that when the families start to kind of demand or want things that we don't think is correct, then we start to feel kind of powerless, and we start to feel a lot of moral distress, and then we start to withdraw. And that actual withdrawal of the relationship starts to, the patients and the families can feel that, and they start to feel betrayed. and that just feeds a cycle. So I'm going to talk a little bit about what is defined as the symptomatic cycle, but before I talk about that in the next slide, I just want to define what we're talking about for symptoms. They can either be the symptoms, what the patient actually has presented with, and then there's disagreement on how to manage or treat it, or they can be behavioral symptoms. Sometimes we see families who we have a hard time getting them to be present, and we have lots of ideas on why it is that the families are not present. Sometimes the families are demanding a particular treatment path or choice that we don't agree with, and so this is the symptom that we're talking about. This is the symptom that the cycle that they define, and so we have this symptom, whether it's the conflict itself or the medical problem, and both the physician and the family and patient are focusing on trying to eliminate from their perspective what the problem is. And by focusing on that particular problem and what the outcome that we're all hoping to get, we're forgetting to focus on important relationships. They get neglected. The patient can sometimes, or the family can be seen as a problem, and when that happens, they can continue to demand relief of whatever that problem is, and then the relationships start to deteriorate. Patient feels and families feel misunderstood and isolated from relationships with the medical team. And then when that happens, then the symptom just intensifies, and it becomes this loop and distracting from relationships with the patient. So what's proposed in this book instead is physician as collaborator model, and the top two boxes we're going to talk about delineate a little bit further, but what's recommended is that we use these universal principles to frame the problem with the relationship, and then use this arch principles to build relationships with the family and patient, to really focus more on relationship building and less on, put aside whatever treatment decision that we're disagreeing about. And from our standpoint, encourages the patient and family, encourages their coping, and remain open to other possible explanations of the problem or other possible solutions to the problem. And then going on and monitoring the symptoms, monitoring, is this relationship getting better? Is the conflict getting better? And if not, continue to use these other principles. And then hopefully at some point in time, we can get out of this and the problem will then resolve. So the universal principles that they talk about are competence, and I think this is really the most important one that I took away from this, is that all patients and families bring a pre-existing set of competencies to the illness experience. They know their experience that brought them to us. They know, their values. They know their lifestyle. They know their hopes and dreams, and they bring those to the table. Connection is important, and we know that isolation and disconnection make things worse and exacerbates the distress. Control is the myth. And then it's important to remember our blind spots and any biases that we might have. And those biases that we have, those blind spots, are the very things that fuel these impasses, that fuel these conflicts. And it's important for us to see our role in and contribution to this impasse. And then it's important to be collaborative, and both the medical team, all of us on the team, as well as the patients and family, that the most important thing is to remember that we should be collaborating to the end result of the best interest of the patient. And then the ARCH tool, this can be used as a prevention tool to prevent these impasses and these intractable conflicts. First, to just accept. A lot of times it's really hard to accept a family who's exhibiting bad behavior and really strong negative feelings. And we're, trying to change the parent's perspective, change their feelings. And the first step is to just accept them where they are. Respect, which requires really active listening and validating concerns and taking the family seriously. And then displaying curiosity and using phrases like, what is the most distressing about this situation? What are you most concerned about? And can you tell me more about that? And then finally, honesty, and just letting the families know that you find the situation frustrating also, and asking the family, how do you think we can move forward towards finding a solution? And then this kind of puts it all together. On the left-hand side, we have our traditional physician as expert model, which works in most situations. And when that's not working, to really switch over to this collaborator model and really focus on the relationship to try and get the problem resolved so that we can help the patient. And now we're going to transition to we have a couple of cases and some panelist discussion.
Thanks, Dr. Monkwitz. Let me introduce our esteemed panel this morning. We have 5 members of the panel. We'll start with our parent panelist, Adrienne Ruiz. Ms. Ruiz has held positions on the PCH Advisory Board as well as the Ethics Committee and advocates for experienced parental input on complicated cases and course of action related to family-centered care. Adrienne served 23 years as a Phoenix police officer and retired in 2014 as a lieutenant. Our next panelist is James Allers. Mr. Allers is Assistant General Counsel of Phoenix Children's Hospital, where his responsibilities include serving as legal counsel to the Bioethics Committee. Our next panelist is Dr. Emma Ross-Katami. Dr. Katami is a staff psychologist at Phoenix Children's Hospital who performs consultation and liaison services for the inpatient medical floors. She's also the dedicated psychologist on the palliative medicine team, where she works with teens and young adults to help clarify their goals of care and complete advanced directives. Our next panelist is Lisa Dowrick. Ms. Dowrick currently works on the PCH Trauma Department as the Trauma Outreach Educator. She has been a member of the Ethics Committee at PCH for over 10 years and has been doing consults as a nurse ethicist since 2008. And finally, our moderator for the panel will be Dr. Megan Land. Dr. Land completed her critical care fellowship at Emory University and currently is a pediatric intensivist at PCH and also serves on the Bioethics Committee. And Dr. Land, I'll hand it over to you.
Thanks so much. So we just have 4 very brief fictional cases that have features of published ethics cases that will illustrate some of the points that Michelle just discussed. I'll present the cases to you, and then our panelists will share their expertise and point of view, answer some questions. And at the end of the 4 cases, we'll open up the floor for a Q&A session to talk about questions or thoughts that you might have about the concepts we discussed or the cases that we present. So the first case is a 5-year-old girl who's admitted to the PICU with a liver laceration after she fell on the handlebars of her bike. Her hemoglobin at admission is 6, and she's a little bit tachycardic with a heart rate of 130, but the rest of her vital signs are totally normal, including her blood pressure. Her physical exam is normal, except for some tenderness and bruising in the right upper quadrant of her abdomen, and her labs all look normal, except for that hemoglobin of 6 with some elevated liver enzymes. A VBG was performed, including a lactic, and it was normal with a lactic of less than 1, but the ICU doctor would like to transfuse PRBCs because her hemoglobin is low and she's tachycardic. Ellie's family, however, is Jehovah's Witness and is currently declining the blood transfusion due to religious concerns. So to start off talking about this case, while this child does have tachycardia, she's not really demonstrating any labs that indicate an oxygen delivery issue. She's not got a lactic acidosis or hypotension, and she has no current markers of end organ dysfunction. So that does give us the benefit of a little bit of time to discuss options with her family and her faith community. So it's important when we discuss these cases that we explore the urgency of the treatment when we're considering whether or not to try to override parental decision-making. So for my first question, what are some of the typical ways that we could come to compromise with the family in a situation like this?
I'd be happy to offer some input as the parent, since this is a kind of up our alley. So looking at, from my perspective as the parent, the risk-benefit that Michelle spoke of, this is obviously an acute versus a chronic scenario for the parents. So it's not something they may have had no experience whatsoever of having their child injured to the point that they have to be transported in an emergency environment. So all of that encompass a lot of high emotion for the family. So when looking at any kind of roadblocks from a family's perspective, looking from the physician or treating physician perspective is going to be your religious, your values, and your cultural. So in this case with religious beliefs, this is their only child, for example. This is a young child. Again, limited exposure to scenarios such as this. If time can be in your favor to either get resolution, if the child is not in an immediate danger, to explain the risk-benefit, but also understanding the challenges the parents are facing with their religious beliefs. really getting to know the family. I think spending time with the family, if time is on your side and on the patient's side, is to really getting to know the family and get away from the business of patient care. If the families perceive, especially those that are not exposed to emergency or chronic conditions, sense a business of patient care, you're going to shut them down right away. The ability for them to then listen to options or to be open to suggestions will be restricted because you've turned this into a business transaction. So really taking that family-centered care approach and understanding that inherent biases may exist, and there may be from a physician's or a nurse's position to impose an immediate evaluation or immediate care. If you have time on your side, get to know the family, remove yourself from the business of patient care, work for family-centered care, and listen. Thanks, Megan.
So, Megan, I would add that PCH does anticipate and try to mitigate this kind of conflict in its refusal of blood products policy. We acknowledge that there are religious objections from some families to blood products. So, and it's important, as Adrian said, to distinguish between emergency situations and situations where a blood products might be necessary, but it's not emergent. This case sounds like it may be neither of those, where we're not sure that it's necessary yet, and it's definitely non-emergent. But one of the ways that we deal with that to mitigate that conflict is that instead of having families like Jehovah's Witness families consent to blood products, we have them acknowledge the policy that we will provide blood products in emergent situations as necessary. And of course, there's a statutory protection for providers to do that without parental consent. But that is one way that we address that.
Thanks, James. I think that's really helpful. So I think it's really a combination of, what sounds like respecting the cultural or religious beliefs of the family, but then balancing that with whether or not this is a true emergency. And like James said, if it is a true emergency and we said the same patient came in, but this time is, hypotensive with lactic acidosis, that's a really different situation. But in kind of the less urgent, less emergent situation that we initially described, where you have some time to sit down, that maybe sitting down with members of the family, members of the faith community to discuss things like blood-sparing treatment options, maybe in your best interest to really try to gain that family's trust and to try to understand as best as you can where they're coming from. So we'll move on to the second case. So this is a 16-year-old boy who was diagnosed with AML at the age of 10. He underwent chemo, and unfortunately during that time he was in the PICU for a month with E. coli bacteremia, septic shock, and ARDS requiring prolonged mechanical ventilation and CRRT. He eventually achieved remission, but then 2 years later at 12, he had a relapse. He underwent stem cell transplant, and after this therapy, he had a lot more issues, graft versus host disease, leading to sinusoidal obstruction syndrome, SOS or VOD, and was fluid overloaded, requiring more mechanical ventilation and CRRT in the PICU for another several weeks. He eventually makes it through this second round of PICU and was discharged home, and has been doing well for the last couple of years, but now he's 14 and he's relapsed again. He was offered the option of CAR T. Even with CAR T, he doesn't have a good prognosis though. So the patient's mother wants this and every option that could potentially prolong her son's life, but the patient has now expressed that he does not want any further therapy. He states that if the new therapy were to guarantee a cure and a normal life for him, he would consider it. But he was tired and didn't want to continue to go through all of this if he was going to die anyway. So for this 16-year-old, Emma, can you help us to understand the growing autonomy of this boy who's experienced a lot of complications with his therapy?
Yeah, so I think this case is on the surface just way different from the previous one we discussed by the age of this minor. So we would really consider him in this instance to be a mature minor, both his age as well as the fact that he has an extensive medical history and his medical literacy is going to be significantly higher than just the average 16-year-old. So when he's able to say that he's not interested in the potential additional treatment, it does not sound like it's for reasons because he doesn't want to experience pain or he doesn't want to be away from his siblings for a while. It really seems as though he has a different grasp as to why he would not want to participate in this. So I think the first thing to recognize his autonomy is to have different conversations between him and his mother, give them both space to have to voice their opinions, to voice their preferences, to express their concerns, so that they're not just hearing each other and then we're creating conflict within the room. It's already pretty impressive that this young man has made it clear that he differs with what his mom wants. So the last thing that we would want to do is to continue to encourage conflict at the bedside when there's already so much going on. So that's not to say don't have these conversations with them, but to do so privately. The other thing is that we would want to make sure that this mother is aware of the degree of pernicious impact, really, that if she were to override him, it would have on their relationship likely, as well as his sense of self, his coping, his mood, his ability to express what he wants and needs, so enhancement of his sense of self. So there's really significant downstream effects on how this child will cope and process and function if his opinion were to be shut down. So a lot of times parents are very receptive. Like Adrienne said, if you just level and have a real conversation with what can happen within a parent-child relationship, if we continue to support sort of this dichotomous you against him type of situation. And ultimately, we know that for parents, there's much higher levels of guilt and depressive symptoms that are associated with decisions that they make for which they don't have their child's assent or permission. So we would want to make sure everyone involved here is educated on not just medically what can happen, but also emotionally and coping-wise what can occur.
Thanks, Emma. I think that's really helpful. And to, be thinking of strategies that help this patient and his mom communicate most effectively to get on the same page about things, I think is the best way to go about it. If we consider a slightly different scenario this time, so another patient with cancer, but this cancer is a relatively benign cancer with good prognosis. So if we said that this was a standard risk ALL kid, but the parents are declining chemotherapy because they'd like to pursue things like alternative treatments and prayer. If we contrast this case with kind of the previous one and the harm threshold, what would that mean for this family in a situation where the outcome is much more positive?
So I can speak to that from the legal perspective, that while there's not a lot of court precedent on medical neglect cases generally, and they're all very fact specific, some factors that courts do generally consider in overriding parental autonomy is when the treatment in question is proven to be effective, when the treatment has relatively low medical risk to the patient, and when the treatment offers significant benefit to the patient by avoiding an imminent harm or death. And looking at the legal framework in Arizona, the neglect statute requires that a provider report medical neglect if they have a reasonable belief that a parent or guardian's decision to withhold treatment will create an unreasonable risk of harm to the patient. So you hear the term reasonableness twice. And when a court is thinking about reasonableness, they're looking for some objective indicator to evaluate a decision. And so in this case, if you have a medical consensus that this is an effective treatment, that it should not cause significant harm to the patient, and that it has a very likely positive outcome for the patient, I think that a court would be more likely to find a parent's withholding of care to be unreasonable.
And James, are there laws that are in place regarding reporting obligations for, I guess, medical neglect or abuse in this case? And who exactly has to report?
So there's a lengthy list of mandatory reporters, but it includes a number of different medical staff members, social workers. It really only requires one person to report, but what the statute says under Title 13 is that if you have a reasonable belief that there has been abuse or neglect, you have to report it. And it's important to understand that there's a significant difference between the standard for reporting abuse versus neglect. For abuse, if there are any facts that indicate abuse, then you have to report. For neglect, again, it's that double reasonableness. It's you have a reasonable belief that there is an unreasonable risk of harm. And that is a more nuanced evaluation.
Helpful. Are there other laws that affect parental authority that are in place in Arizona?
There are, and I think Emma alluded to this in talking about the central role of family in society. Different states view the level of parental rights versus state intervention differently. In Arizona, the right of parents to make medical decisions for their children in the absence of other laws, like the neglect law, is enshrined in the Constitution. So it's something that in Arizona is considered to be, parental autonomy is considered to be very important. There's also some administrative law considerations. I'm sure if there are any social workers on, or if you talk to the social work team that deals with these cases, they would talk about their obligations under the Board of Behavioral Health, and likewise for doctors and nurses under their respective boards, they have obligations to follow the law as a condition of licensing.
Right, that makes sense. Lisa, can you help us better understand kind of the difference when we discuss with families that are refusing care when there's a poor prognosis for a child, when we undergo a specific treatment versus a good prognosis for that child if they undergo the same treatment?
Sure. I think it's important that, as Adrian said, you find where the family is coming from and how much they truly understand. I think a lot of times when I get called into these situations, both sides, the family and the medical team, are divided, and there's a lot of anxiety. And so I think one important thing I'd like to get out there is to call us earlier so that we have time to sit with the family, talk about this, figure out what's going on, where they're coming from, and assess their understanding. But if it's something that's, again, you go back to the harm threshold, that parents generally are trying to do what's right, what they feel, they believe that they're doing the right thing for their child, and we see it differently. So when it's something that there's going to be harm to the child, and it's imminent harm, that we don't have time on our side, then I think that's when we have to push to intervene. But it's so important, because without the family's buy-in, then things don't go well down the road, as we all know. So they're not going to show back up for treatment. We lose the kids in the system sometimes. So I think it's really important to decide, do we have any other alternatives for treatment? Can we live with what the family is proposing? Or is it going to cause serious harm and morbidity or mortality to this child? Then I think that's when we have to seriously intervene. But I think it's important that we work with the families and the children. I've been on several cases where the children and the child and the family disagree. And I think it's real important, as Emma said, that we have to maintain that family unit. So we really have to work and see if we can see both sides. And a lot of what we do is mediation when we get called into cases. It's not that we're there as the medical expertise. We're not. We're there to try to mediate and do what's the best thing for the child, and with that, what's the best thing for the family, because they are truly a unit.
Super helpful. I think always keeping an eye on, communication and making sure that we're doing our best in terms of communicating with these families is probably the most important thing of all. So we'll move on really quickly to the third case. So this is a 7-year-old boy who's admitted with multiple injuries after an ATV accident that required vascular and skin grafts. Not been eating well since he was admitted 9 days ago, and he's losing weight. Medical team is becoming concerned about his nutritional status and his ability to heal these extensive wounds. And they'd like to place a feeding tube in order to initiate enteral supplemental nutrition. But the child is very anxious and the parents are refusing a feeding tube. So how do we go about the refusal of an intervention like this from a younger child, a 7-year-old, as opposed to the earlier case where we had a teenager?
One thing I just wanted to mention, I think it would apply to all the cases, but I think if we come from a position of first to understand before we can be understood. So in this case, the child is much younger. Again, this is an acute or emergent kind of trauma the child has experienced, the family as well possibly. So getting to know if there, again, always asking if there are other children at home. I'm shocked that sometimes that's sometimes never asked. So I think that elevates the level of the family's understanding of maybe what they're experiencing. If they have older children, maybe they've had slips and falls already, maybe they've had other acute issues or emergent issues with other children, so they're experienced. But and then what's the support like at home for, say, this 9-year-old? If he's an only child, this could impact his decision making as well, and his fear. So I think coming from a position of first understanding before we ourselves, if I'm a physician or a nurse, before I can be understood, is really showing and encouraging the child to ask questions, acknowledging their fear or concern. To me, probably the most, not that the physicians are not important, they're very important, but I will tell you, as a family member who spent many a night in a hospital, the nursing staff is key. The nurses spend a lot more time with the patient and the family than the physicians do. So finding that advocate that the patient and the child, maybe if it's not even the same person, but it's centered around the family, that the child and the parent can respond to and build a rapport with. Also, is time critical in this scenario? Are we able to get at least IV fluids in the child for dehydration? Is the enteral feeding really necessary right now? Is the next 24 hours going to be critical, or the next 3 days? So as a patient family, again, if we come from a position of, if the family senses that there's a punitive outcome, if they don't do something, you may lose the family very quickly. So really building that rapport and listening.
I think that's a great point. So just keeping an eye on, whether as a medical team we believe that this intervention is truly life-saving, or if it's just supplementary to our ability to provide care, and how those two situations are pretty different. And in this case, this child is not going to die from dehydration. It's more about adequate wound healing and making sure that they have the best outcome. So it just gives us more time, like Adrian said, to get the family on our side and to all kind of get on the same page about things. Emma, just really quick, how does this change in a younger child versus an older child? Because I know you talked about assent earlier, and so would that be kind of the situation here, since this is a 7-year-old as opposed to a teenager?
Yeah, so this is very different because a 7-year-old has different cognitive capacity and ability to plan and judge and to make future forward decisions than a 16-year-old. So the provision of assent in this instance would not be weighed as highly as provision of assent for the 16-year-old. However, that doesn't mean that we should not include them in decisions. It's just that they should not be responsible ultimately for making that decision or having their decision be of equal weight to the parents. What I will say is that a 7-year-old is like a sponge to what their guardians or people that they trust the most believe and think and say. And so, again, if we have guardians at bedside adamantly refusing this, saying it's not safe, or whatever their beliefs are as to what their concerns might be, that is what the child is likely to internalize as well. So we want to try to help the family change the language around nutrition, at least when they're at the bedside. Of course, being able to ask the questions that they want to the medical team privately. But it's unlikely that this 7-year-old just spontaneously wouldn't want a feeding tube because they don't think it's consistent with their quality of life. It's probably they don't want this type of nutrition because they've heard someone say something about it, they've seen the tube and it looks scary. So talking to the child about what is underlying their concerns and then bringing in the appropriate support. So in this instance, the first thing that comes to mind would be getting Child Life involved to meet with this patient, to show them what type of enteral nutrition the team is thinking about, to let them be more involved, to ask the questions, to talk to them in a way that's developmentally sensitive. A lot of times just this inclusion and care can minimize some of the reduce some of the distress that the child is exhibiting. Also, Child Life and psychology can work with this child to come up with a cope ahead plan so that they have more control during placement of the feeding tube, that they're more comfortable, and that there's a scenario in place for after the tube is placed so that they feel more successful. So I would also encourage the team to utilize the resources that the hospital has, and for the medical team to not feel like it's their responsibility to reduce this child's anxiety, to call in some backups and support.
That's a really good point. And I think Child Life can really make some good headway with kids that are this age. And I think it seems like if you can get the child on board, you probably will make a lot more headway with the parents. Are there any specific communication strategies that you think are helpful with parents when a child is anxious like this and isn't having, we're not having good success convincing the child that whatever intervention is a good idea?
So a lot of times it's about partnering with the parents. So again, if the message in the room from the parents is that this is something that we don't want, we're not comfortable with this, it doesn't matter what anyone on the medical team says or does, that child is going to divert to looking for their parents, as they should. That is the person that keeps them safe, and that is the person that they have come to trust. So it's really important as far as communication for the team to partner and collaborate, as Michelle talked about extensively, really take a collaborative approach with the parents to devise what is the plan that they feel most comfortable with, that the medical team is also comfortable with, and then how can they present that information as a united team to the child. So if a parent is more comfortable being the one to tell the child what will happen, that's great, but the team needs to know the language that they're going to use so that we can also use the same language when we're at the bedside. If they want Child Life or someone else to be the one to provide that information, then we should be as receptive as we can to help put whatever plan they think would be best for the child in place. So while the medical team is the expert of the medical care, we need to always remember that the parent is the expert of what is best for the child from an emotional standpoint. And so the strategy that I defer to the most is sort of a fact-based, here is what the medical team thinks is best. Now you tell us what you think is best as far as how we work with you and communicate this to your child to make this process as least stressful as possible. For older kids also, I'll just do a quick plug. For older patients, I'll often use a document called Voicing My Choices, and this outlines all different types of preferences around medical care that minors would be interested in or not interested in. It's not legally binding, which is why if they're over 18, you need to do formal advance directives. But if there is some contention between parents and a child with respect to any type of decision, getting a neutral third party, like someone on the medical team or psychology, to work through this document, Voicing My Choices, usually for kids 12 and older, and My 5 Wishes for kids under 12, can be really helpful for parents in seeing what is it that the child really wants, and if for things that they don't want, why, not just I don't want it, period, but really what's underlying that decision of resistance.
That's super helpful, Emma. I think I had never heard of those tools. So those are really nice tools for standardized communication that sound like they could really help some families to get on the same page as the child that they're trying to work with. And I'm hearing a lot of the same themes from all of you, and a lot of those kind of center on Adrian's comment about leveling with the families and with their children. So I wanted to leave a few minutes for questions at the end. I do see a couple of comments so far. So one is from Susan Stevens, who says that the treatment for cancer against parents' consent is quite judge specific. And she says many judges will side with parents that they know what's best for their child. And I think, Michelle, you talked about that a little bit earlier, and I know you've been reading a little bit about that. I don't know if you'd like to speak to that. Michelle, you're muted, sorry.
Could you repeat that question?
Oh, sorry about that. Susan Stevens just commented that treatment for cancer against parents' consent is quite judge specific, and that many judges will side with the parents that they know what's best for their child, which I know you've been reading a lot about lately, that in the oncology literature, there's actually quite a range of what's acceptable in terms of a treatment when there is quite a heavy risk burden. So I think you've seen that a lot as well, that it seems like there are a lot of different kind of opinions that are based on which judge and kind of what they hear.
That's definitely the case. I've seen some judgments that the one that I tend to think is really reasonable is the 70% of chance of good survival prognosis. But there are, like, I think James was talking about having objective facts to support the burdens and the benefits of the treatment. And if we can come up with, well, this is the percent chance of, 1 year survival, 5 year survival with treatment, that is taken into consideration, as well as what the risks are. And then, there's some literature that talks about some of the judges who've talked about what's the real risk of if we're talking about chemotherapy, for example, what are the risks that there will be significant morbidity and mortality with that. So I think that those numbers are weighed heavily upon.
And then Dr. Rosenberg just wanted to comment that in the research realm, that federal regulations do require assent for most types of research for kids age 8 to 18. But that they may override refusal of assent if the research offers the prospect of direct benefit to the participant. And I know research regulations often differ somewhat from what we do in clinical medicine, but I'm not sure if anyone would like to speak to that comment.
No, I mean, I think it's important to try to get assent for any decision that we would be trying to get consent from parents for when the child has capacity. If they're over the age of 8, I think that's appropriate, but it's certainly different with IRB and regulations with respect to whether you're able to proceed in the event that assent was not obtained, different in research than clinically.
Right. And then one more comment just came in that many times the family unit is not unanimous in their opinion when these kinds of decisions have to be made, and there can be opposing opinions. So Emma, you may be able to help us with this one. How do you deal with kind of a situation where the opinion is not unanimous amongst the family?
Yeah, these are always the toughest cases. And I think the first thing that comes to most people's mind is that the decision isn't unanimous between the patient and the parent, but oftentimes more what I've come across is the decision isn't unanimous between parents. And we actually have a situation where a child and one parent are more on the same page or more aligned, which obviously creates a lot of tension within the family. So there are different ways to approach this based on how much time you have, which is not a satisfying answer. But if this is a decision for which you can take a few days or a week and meet with whoever the opposing sides are separately, try to come to a better understanding of what's beneath the opposition, as well as using the best interest and best standards, ultimately guide what the medical team's recommendation is. This is best case scenario. If you're in a feet to the fire situation and you have to come up with a decision quickly, it would ultimately defer to the medical team's recommendation, and then looking to whichever adult was also in agreement with that contingency. I'm not sure, James, if you wanted to weigh in about legally what would happen in that situation if it were two guardians who disagreed.
Yeah, I mean, legally, we need the consent of one parent or guardian for a treatment, but if the parents are in direct conflict as a practical matter, we try to resolve that, because it's, you know, it's not really a tenable situation for the medical staff to be working with, trying to navigate through a, you know, ongoing conflict between the parents about a treatment decision. So we do try to direct the parents to resolve those disputes, but legally you need the consent of one parent.
Okay, I just wanted to thank everyone for participating today. Thank you for all your questions, and thank you to the whole panel for giving us so much interesting insight. I know Michelle and I both wanted to make sure that if anyone is interested in a group specific or specialty specific kind of breakout session, that the ethics team is happy to facilitate that. And so if you want to reach out to either me or Michelle via email, we're happy to get that set up. And then Michelle, I know you just wanted to quickly plug this Breaking the Cycle book. I think you're still muted, but.
Thank you. Yeah, this is a great book. The author is cut off, but if you type in the whole title, I think you should be able to get it up.
All right. That's great. Thank you, everyone.